Welcome in everyone who's starting to join us. Good afternoon and welcome to the STI Expert Hour webinar. I'm going to give us a few more moments to allow everyone to join the Zoom room and then we'll do our introductions. All right, welcome again, everyone. We're waiting for a few more people to enter the room. The numbers are rising, so just hold on there. We'll start momentarily. Welcome, everyone. Good afternoon. And welcome to the STI Expert Hour webinar. Today we have the illustrious Dr. Kathy Yang joining us, and she's going to be presenting on medication conundrums in STI management. My name is Dr. Sharon Adler. I am clinical faculty at the California Prevention Training Center, and I'm going to be emceeing and helping with a Q&A at the end of the session. But first, I'm going to go over some important introductory slides. All right, a little bit of information about the California Prevention Training Center. So we are a multidisciplinary and capacity building assistance center. We are funded by the Centers for Disease Control and Prevention, and we are a member of the National Network of STD Clinical Prevention Training Centers, the NNPTC. We provide virtual and in-person training events, technical assistance, clinical tools, lots of resources, and STI clinical consultation, focusing on complex STI issues in patient care. You can learn a lot more about us at our website, as well as at the National Network Prevention Training Center websites, and there are links to both of these websites at the bottom of this slide. We are part of the National STD Clinical Consultation Network. This is funded by the CDC. We answer calls within our region. This is a really wonderful resource for clinical providers. And so it's an online clinical consultation, and you can submit interesting clinical cases, complex STI questions to us, and a subject matter expert will get back to you by phone or email per your request within 1 to 5 business days, depending on how urgent your clinical consultation is. So I really highly recommend this resource to everyone that's attending this webinar. Here are our financial disclosures. We do not have any disclosures today. Regarding CME, this webinar is being offered at 1.25 units. And over the next 2 slides, I'll go over all the details related to CME. And there are a lot of details here that are very important. So for the CME requirements, you have already registered for the webinar, and you registered on the NNPTC website. You need to have registered by the deadline. Please note the deadline is now closed. And everyone who is attending, if you want to obtain CME, you need to stay with us for the full webinar, watching it live and in full. Unfortunately, we cannot give CME credit to folks who are viewing this recording, if you're viewing this via recording. We also can't give partial credit if folks are attending just partially, and your attendance is going to be noted as you sign on today. Importantly, you are going to receive an email with the post-course survey evaluation, and that's going to come in by February 24th. So you need to complete this in order to get your CME. So everyone who was registered through us via the NNPTC website, you are going to receive an email, and the email is going to come from training@nnptc.org. That's going to give you a link to the post-course survey evaluation. And you are going to get that link within 24 hours of today. The notification is sent to the email that you use to register. And to ensure that you actually receive this, please make sure that you have added training at nnptc.org to your safe and trusted senders list. You can also check your spam and junk boxes if you do not see the email in your main inbox. Our CME is processed through the University of Nevada, Reno School of Medicine. And so if you meet all the requirements for CME, you're going to receive an email from us, captc@ucsf.edu. That will come approximately 4 to 6 weeks after the post-course survey evaluation deadline. And they will provide you with a link, and then you can download your certificate. Again, the notification regarding your certificate is going to go to the email that you use to register for this webinar. To ensure that you receive this email notification, make sure that captc@ucsf.edu has been added to your safe and trusted senders list. And again, please check your spam and junk folders if you do not see the notification in your inbox. And I realize this is a lot of details, but you can always contact our administrative staff, and I'm going to share their emails with you in a moment if you have questions about the CME. All right, moving on to the Zoom webinar, a few housekeeping tips. So we have so many people that are attending today. Our participants are up to almost 300. So unfortunately, we can't see you. We're not going to have your microphone or videos on during this webinar, but you can connect with us via Q&A. So the Q&A will be turned on and you can access it throughout the webinar. To use the Q&A, click on the Q&A icon, this icon that you see in the middle of the screen here. And this icon is going to be at the bottom of your Zoom screen. Once you click on that, you can type in your question and then click submit to submit it to us. If you want to click and send it anonymously, then you select anonymous. You can submit questions throughout the webinar up into the last 2 minutes of the Q&A section. During the webinar, I will be reviewing the Q&A and may answer your questions directly if there are things that I can address. If they're more specific to Dr. Yang, I will hold on to them and present them to her at the end of the webinar. In addition, you can submit questions that are more administrative, related to CME or other technical issues, and 2 of our clinical team will be able to help you, Elizabeth Olson and Lauren Blakely. So thank you for that, for Elizabeth and Lauren being on the webinar today. All right, here is the email, and if you have any questions about the CME or questions that are administrative during the webinar, and that is to contact our clinical program manager, Elizabeth Olson, and her email is listed in the middle of the slide. All right, so now I'm going to introduce Dr. Yang, and I want to say I have utilized Dr. Yang's expertise in pharmacology for, I don't know, almost 15 to 20 years now. So I really appreciate that she's here with us today. She's a great presenter, and she's been such an incredible resource to us at the CAPTC. So it's wonderful to have you here today, Kathy. Dr. Yang is a health science clinical professor in the Department of Clinical Pharmacy at the UCSF School of Pharmacy. She is also an infectious disease clinical pharmacist in the UCSF Medical Center. Dr. Yang specializes in the treatment of multi-drug resistant gram-negative infections, and her research interest focuses on the pharmacokinetic and the pharmacodynamic optimization of antibiotic dosing for the treatment of infectious diseases. And with that, I'm going to stop sharing my screen and allow Dr. Yang to share her screen.
Thank you, Dr. Adler, for that very kind introduction and for having me here today. Here, I'm going to start sharing my screen. We just talked about, let's see, get this together. There we go. Can everyone see this? All right, so thank you so much for having me. These are my objectives for today. And as Dr. Adler mentioned, I love PK/PD. So we're going to talk a little bit about PK/PD and what that means from a clinician standpoint in terms of dosing and administration, especially with regards to antibiotics. So in the past, we talked about PK/PD for antivirals, and today we're going to really focus on antibiotics. We're going to develop a plan for common drug dosing issues, side effect management, and allergy management. And because there's no way any one person can know everything, I thought we could touch on some trustworthy resources for you to look for information with regards to drug-drug interactions, breastfeeding, etc. And I'll give you some tips for which are my sort of go-to places. So I have no disclosures relative to this presentation. And so the first thing we're going to talk about is basics of PK/PD and why it matters. And I've sort of touched on this in the past before, but as Dr. Adler mentioned, I love PK/PD, so bear with me on this one. And so the first thing I want to talk about is really what is PK and what is PD. So PK is really pharmacokinetics, and what it is what the body does to the drug once you take it. So when we talk about pharmacokinetics, we're talking about this ADME, absorption, distribution, metabolism, excretion. And that gives you this concentration time curve that you see on the right. So this concentration time curve changes depending on the drug that is given, and how your body handles that drug, how your body metabolizes it, how your body excretes it. And then the clinical effect that we get from the drug is called pharmacodynamics. So this is the concentration of the drug leading to the effect in your body. And that effect in your body can be almost anything. It can be a lowering of blood pressure. It can be a lowering of cholesterol. So that is a pharmacodynamic outcome. With regards to antibiotics, that usually refers to how much bacteria we can kill in a certain body space over time. So of course that changes depending on where the infection is. So if it's in the lungs versus it's in the kidneys, and it has to also take into account how much drug actually gets there. So how much drug do we actually need to take to get an effect? And so that really depends on lots of different things. So where does it need to go? So whether or not the drug stays in your blood versus it needs to go to the liver versus it needs to go to a lung, or for STDs to sort of the reproductive organs, where it needs to go makes a big difference, and how much of it can actually get there. So there's a lot of work that goes into looking at site-specific PK and site-specific levels. And we know that from our PrEP experience that drug levels are different in different tissue spaces. How fast do we need it to get there? So obviously when you give an IV push or an IV bolus, that's an instantaneous absorption, and you get a peak concentration right away. That's different from when you take something like an oral drug where there's an absorption phase that needs to take place. So you have to give that time to dissolve into your body and to get into spaces it needs to go. How long does it last in the body? That is based on a lot of different things. First, it's the half-life of the drug. So some drugs have very short half-lives, and then they have to be dosed very often. And some drugs have very long half-lives and have to be dosed less often. And then, of course, we have sustained release products. We have drugs that are formulated specifically to give a certain level over a certain amount of time. And those are things like our penicillin products. And then, of course, we have to think about toxicity. More isn't always better. So at some point, you've killed off all the bacteria. You want to make sure you don't kill the person in the process. So when we have drugs that have a very wide therapeutic window, so there's a big concentration difference between how much we need versus how much is toxic, that's great. That's what we want. But sometimes that difference is not so big, and that gives us problems in terms of dosing. And of course, what about drug-drug interactions? So we have to remember that drug-drug interactions, although they're metabolic, they actually do have very specific pharmacokinetic effects. So giving drugs that cause a decrease in metabolism will give you very, very high levels. And that, of course, can get you into trouble when we get into toxicity. So this is basically my cartoon graph of antibacterial PK/PD. And this really answers the question of how much do I need to give and how often. And this really changes depending on the drug class that you're using and the bacteria that you're treating. So if you look at this graph, you have this concentration time curve, which is in this blue here, and that's the concentration of drug in your body once you take a dose. There are different measures here with regards to the concentration. So you can see here that the top concentration is called the Cmax. So that's the maximum concentration. This sort of shaded out area is called the area under the curve. The area under the curve and the Cmax are both measures of how much exposure of the drug you have. So a higher Cmax means the higher concentration you get in the body. That doesn't necessarily always equate to area under the curve, because you can have something that doesn't get a very high concentration, but lasts a long time in your body, and that also gives you a high area under the curve. And then you have this thing down here called the free time over MIC. So before I go into that, I have to explain to you sort of what the MIC is. So for all of our colleagues out there, our medical colleagues and our ID colleagues, this MIC is sort of a thing that's ingrained in our head. It's the minimum inhibitory concentration. So that's the minimum concentration we need to give a person in order to kill the bacteria that we're talking about. And these MICs are standardized by national organizations and also by CDC. So these numbers are fairly set. And so how much drug we need to give for an antibiotic really has to depend relative to this MIC. So if we're talking about an aminoglycoside, such as gentamicin, the best kill that you get is to have a high Cmax to MIC ratio. So that's kind of a funny thing, right? So it doesn't matter how much over the MIC you are for how long amount of time. It just means you need one point that is as high as possible to be over the MIC. So that ratio, if you're about 7 to 10, you're really good. Of course, that gets you into trouble because, as we all know, giving high doses of aminoglycosides gives you toxicity in your ears and your kidneys. And then you have this AUC-MIC ratio. So then it's someone who is like actually drawing out the curve and figuring out the exposure and having a ratio of AUC over MIC that is also as high as well. So the higher these numbers are, the better. And then you have this thing, which is what probably is the most intuitive to you. And this will be free time over the MIC. And this is how we dose beta-lactams. So things like penicillins, cephalosporins. What it basically means is we don't care how high we are over the MIC. We just care that we are over the MIC. And the longer, the better. So it's percent free time because there are certain drugs that are highly protein bound. And so only the part that is not protein bound is actually the part that's active against the bacteria. So we want this time over MIC to be as long as possible for things like penicillins or cephalosporins such as ceftriaxone. And that has really informed how we dose for syphilis and how we dose for gonorrhea. So speaking of gonorrhea, this is, I'm sure, a graph that is very, very familiar to you. It looks at the percentage of Neisseria gonorrhea that has increased resistance to ceftriaxone and cefepime, which is our third generation cephalosporins, and azithromycin, which is our macrolide. And you can see that over the past 10 or 12 years or so, the amount of azithromycin resistance, meaning an MIC greater than 2, has really gone up over time. And you can see down here that for ceftriaxone and cefixime, it's stayed fairly low, but it is also on the creeping up side. So this has really informed our dosing for ceftriaxone since the 2020-21 guidelines came out, and also why azithromycin is really not used for Neisseria if we can help it. So going back then to our concentration time curves, this is a curve that is looking at cefixime 400 milligrams PO times 1. This is, of course, not the dose that is used now. Now the recommendation is 800. But the reason I show this is because this really informs us why we had to go to the 800 milligrams. So you can see that the MIC breakpoint for cefixime is 0.25. So anything that is above 0.25 is considered resistant. Anything below is considered sensitive. And because we're looking at a beta-lactam, we said that the pharmacodynamic target attainment means that we have to be over the MIC for as long as possible. And for Neisseria, that comes out to be 20 to 24 hours. Okay, so this is why we try to optimize those single dose therapies. So if we can be over the MIC for 20 to 24 hours, then we have a good, very, very high chance of eradicating the bacteria. So you can see then there are two curves here. There's one that is a C total, and that's a total concentration. And there is this one that's CFU. And CFU is basically the concentration that is unbound. So that is the not protein bound, and it's really the concentration that is active against Neisseria. And so with 400 milligrams, you can see that we are only over the MIC up to about 15 to 16 hours. And if we want to be over at 20 to 24 hours, which is the second line, you can see that this area between the two arrows is basically the time that we are not going to hit our pharmacodynamic target attainment. So with 400 milligrams PO times 1, we're only going to be over MIC about 15 hours. So this is why the new dosing actually goes for 800, because the only way to be over the MIC for the full time is to either decrease the MIC, which doesn't happen, right? Because that would mean the organism would become more susceptible, or we have to increase the dose. So that's what informed the dose to move to the 800 milligrams PO times 1. So that's for cefixime, and this is the data from that study. This was actually based on Monte Carlo simulation. And you can see then they didn't actually model the 800 milligrams times 1, but they modeled 2 doses of the 400. And you can see that if you had 2 doses of 400, you would be over the MIC of a 0.25 for about 22 hours. So you hit the target attainment. So then when you do the modeling with the 800 times 1, you're close as well. So what does that mean for ceftriaxone? In the past, we would do ceftriaxone 250. And so the breakpoint that CDC uses for ceftriaxone for Neisseria is actually anything greater than 0.125. So for cefixime, it was 0.25, and for ceftriaxone, it's 0.125. And so these MIC numbers are actually very specific to the organism that you're treating and to the antibiotic that you're using. I know a lot of clinicians go for the rule of thumb as I'm going to look for the MIC that is the lowest. That doesn't always work when you're crossing classes between, say, a cephalosporin and a fluoroquinolone, because the pharmacodynamics of those drugs don't necessarily, they're not equal. So it's a little bit apples and oranges. But for here, you can see that for ceftriaxone, because the breakpoint is set at 0.125, if we use 500 milligrams, we are above the MIC for 32.8 hours. And so the longer, the better. And you can see with the 250, you would have been pretty close, but you would not have caught anything that was resistant. So anything that had a higher MIC, you would have missed it. So that was the rationale for going to the 500 milligrams. Okay, so then that was for cephalosporin. What does this mean for penicillins? And this goes to one of the most common questions I had been receiving over the past years in terms of the interchangeability of the products. Especially when we're talking about treating CNS disease. And so again, which prep we use depends on what we are treating and where does it need to go. And so this is the concentration time curve for 3 different preparations that we are all very familiar with. We have the aqueous, the procaine, and the benzazine. And so before we talk about the individual PK, the one thing I also want to mention is there are lots of names for the aqueous IV version. And depending on where you look in the guideline, it's called aqueous in some places and it's called crystalline in other places. It's basically all the same thing. So the aqueous penicillin G is also the crystalline version. And there are actually two formulations. There's a salt form and there's a potassium form. So they're all basically the same. They all dose the same. And whether or not the pen sodium is used versus the pen potassium is used really depends on which formulation the hospital can get. And in some cases, it may be modified based on the patient's renal function or sodium load. If they have a tendency to hold on to a lot of salt or they need to be salt restricted, you may use the other one. But for the most part, they are interchangeable and the names are interchangeable. So you can see that with aqueous penicillin, you get these very, very high peak concentrations, but the half-life is really short. It's only about an hour. So that's why you have to dose it really frequently because the level goes down so quickly. Whoops. So the other thing about aqueous penicillin is, again, when we're treating something like a CNS infection, you want to get high levels into the CNS. And the only way you can do that is with these high IV doses. The next formulation you have is this procaine pen, which is not the same as procaine benzathine. You can see the procaine pen actually has levels that are lower than the aqueous IV, but higher than the IM. Okay, so sort of in this intermediate part. Although this curve that you see is only with the IM procaine, when you give it with probenecid, what happens is you inhibit renal secretion and actually the levels get even higher. And that's why it can be used as an alternative for CNS disease. You would never use benzathine for CNS disease because you can see you never get these high peaks and you just get these very, very low levels. And that's okay because when we talked about PK/PD, remember, it's the time over the MIC that matters. And for something like syphilis, that number actually hasn't changed, or we don't know if it's changed. And it's about 0.018 to about 0.3 micrograms per mil, depending on where you look. So, and that number hasn't changed over time. So because of that, we can get away with these very, very low doses of benzathine when we're talking about treating syphilis. Okay, so here's our first poll question for you guys. This is case one, a 24-year-old transgender female on day 3 of doxycycline 100 milligrams POBID. She calls your clinic to tell you she forgot to take her morning dose of doxycycline. It is now 2 p.m. What do? Do you advise the patient to take the dose now and take the next dose at the normal time? B, skip the dose, take your next dose at normal time. C, skip the dose, double your evening dose. Or D, take the dose now and move your next dose, otherwise known as retiming. Can we launch the poll? All right, how are we doing on the polling?
74%.
Okay, we'll give you a couple more seconds and then we'll take a look. All right, let's see what you guys said. Okay, so most said A, take the dose now. That was 59%. The next most common was take the dose now, move your next dose, otherwise known as retiming. And then the third one was skip the dose, take your next dose. And then we did have a few people who said skip the dose and double your evening dose. So the reason I showed this, thank you, is just to show there isn't really a consensus. So what happens when we take a pill? So let's see if we can sort of get down to some data. So this is what your kinetic curves looks like when you take an oral drug. And you can see that you hit the steady state concentration in about 3 to 4 half-lives. So for doxycycline, with a half-life of about 18 hours, that turns out to be like 3 days, okay? So it takes you about 2 to 3 days to get to steady state. And you can see then that when you take a loading dose, you can actually get higher quicker, but it still takes you 3 to 4 half-lives to get to steady state. But you can also see then when you miss your dose, sort of makes a difference, right? So if you miss your dose early on when you're trying to still get to steady state, it's more impactful than if you actually missed your dose later on in therapy. So then this is a really interesting article that I found from last year where a bunch of mathematicians, pharmacometricians, tried to model what happens when you miss a dose versus if you skip a dose. So on the left-hand side here, you have what happens to your drug concentrations when you take the dose late and the next dose on time. So assuming all linear kinetics, you can see here that the black level, the black curve, is what your levels would look like if you took it perfectly. And then the blue curve is the fact that you missed this dose here so this is missing the 1, 2, 3rd dose, and you took it late before your 4th dose, and then you took the rest on time. You can see that you dip pretty far down low, but you catch up. You catch up because your next 2 doses are close to each other. You have a period where you're over your steady state concentration, and it sort of works its way back down. Okay, and this row is basically shows your deviations in your drug concentration. So the row minus is your deviations below your steady state, and your green is your deviations above. So you can see that there's harm done, or there is deviation, but you catch up pretty quickly. So what if you skip your late dose and you take your next dose on time? Okay, you don't double, but you just take it on time. And you can see then if you skipped your 3rd dose, you drop down just as far as you did as the curve before, and you take your next dose on time. It takes you much longer to catch up to get to steady state than if you had just taken the dose. So you can see here there's a lot of deviation in dosing curve, and there's a lot of catching up you would have to do. Of course, all of this depends on your rate of absorption, the rate of elimination of the drug, and how long you delay, right? But this is just an average of sort of what happens. So you can see there's a little bit more harm done if you skipped it than if you just took it. So then this gets to be an interesting question. What does it mean to have a missed dose? And this is based on a study that was pretty old. It's done in 2007. And they asked a bunch of African-American persons with HIV who were seen in an inner city clinic. And it was a case mix that included both Medicaid patients as well as private insurance. And they asked the patients and they asked the clinician, what does it mean to miss a dose? And you can see there's a lot of variation on what that means. So 24% of the patients thought a missed dose meant 2 hours. For physicians or clinicians, they thought it was greater than 50% of the time, was a very common thing to say. There's variations in whether or not they thought it was greater than 6 hours. And there is differences in whether or not people thought if you just took the dose at any time during the day, if that actually counted. So 13% of the patients said it's not late, even if you took it between 12 hours and a day late. And then even clinicians said it's not missed if you took it anytime during the calendar day. And then what do you do about it? So 47% of the patients said they would take it right away. 35% of the providers just would say take it right away. 12% of providers actually said just skip it. And then 53 of them were a little bit more philosophical and thought it would depend on the duration of delay and how often you took the drug. The one thing that most people agreed on was you don't double up. And interestingly, there was this common rule of thumb of the midpoint rule. The midpoint rule was basically if it's late and it's before the midpoint before the next dosing interval, I should take it. If it's after the midpoint, I should skip it. So for instance, if you're taking a Q12 drug and I'm late within the first 6 hours, I take it. If I'm late after the first 6 hours, then I skip it. So what does the evidence say? So we know that adherence is problematic, and that few drugs actually come with very specific instructions on what to do if the dose is late, skipped, or vomited. Less than 50% of patients are told even what to do, and there's wide variation, and there's no good studies. I put in the math just to show you that how intricate the pharmacometric modeling was in order to even come up with the concentrations of what are the deviations missed. So is there an evidence-based rule of thumb? And the answer is not really. So looking at Lexicomp and Micromedics, these are basically the two most reputable drug information sources that we have out there. You can see that the information is not very specific, and there's a little bit of variation. So take as soon as you think as soon as you realize that you missed it. That was clear. But Lexicomp said, if it is close to the time for your next dose, skip. Micromedics said, if it's almost time for your next dose, then take it. Wait until then and then take. So what does that actually even mean? So what is the difference between close to time versus almost time? And for patients, that leads a lot to interpretation. Lexicomp also said, do not take 2 doses at the same time or extra doses. And Micromedics frame that as, do not take extra medicine to make up for a missed dose. Would you take an extra dose? I think that's a difficult thing to interpret. In my opinion, if you missed your antibiotic and you skipped it, say, you should tag it on to the end because it's a finite duration of therapy. This is actually language that I got out of the doxycycline package, the Lexicomp information sheet, but it turns out it's the same information for all drugs. So, whether or not you're talking about an antibiotic with a finite duration of therapy versus something that's chronic, I think that also warrants a little discussion. And so there's no good US federal guidance. Actually, FDA is actually thinking about this now, and they will come up with new guidelines on, giving better information on what to do if you vomit it or if you miss it. The NHS actually has a little bit more specific information. They actually tell you what to do if you're less than 2 hours late. And they also tell you what to do if you're after 2 hours late. And the after 2 hours late is then qualified by your dosing interval of once or twice a day versus more often than twice a day. So this I felt like was a little bit more specific and a little bit more helpful. It's still not perfect, but it gets you closer probably to what you need to be. Case 2, 32-year-old female taking metronidazole 500 milligrams POBID. She calls you to tell you she vomited about 15 minutes after taking her meds. You advise her to do the following: take another dose, take next one on time. 2, take another dose, skip the next dose. C, skip the dose, take the next dose early. And D, skip the dose, take the next one on time. So this is similar to the other question. The only difference between this one and that one is you have to factor in drug absorption. Okay, let's see what the answers are. Take another dose, takes next one on time. Okay, skip the dose, take the next one on time. All right. So, and this was a little tricky because I put 15 minutes, so that's pretty quick. So let's see, what does the data show? And again, these are questions that don't always have a perfect answer, but let's see what we find. So again, looking at drug absorption, where does the drug go? So the drug dissolves in your stomach, but the absorption actually takes place in your small intestine. So depending on what is going on in your gut, that actually makes a difference on how fast it gets to your small intestine, right? So and that of course depends on your gastric emptying time. If your stomach is empty, you can see that's really quick. You are pretty much absorbed within 30 minutes or so. And if you have a full stomach, or you have a lot of things in your full stomach, that can actually get pretty long. So then you're talking about 2 hours to perhaps even longer. But for the most part, if we're talking about an empty stomach, it's really fast. And so looking on the right-hand side here, this is sort of a graphic of what happens to the drug once you take it. And so we're going to revisit this when we talk about drug interactions, but you take the drug, it goes into your stomach, it dissolves, then it goes into your small intestine. It gets hit by all these different transporters and enzymes, and it goes into your portal vein and into your liver for metabolism. So it has to get to the small intestine first. So factors that affect this dissolution and absorption, of course, there's medication factors and there's patient factors. So medication factors include the formulation. So liquids obviously go fastest, followed by immediate release and then sustained release. Big pill sizes do worse than small pill sizes. And there's some dissolution kinetics that we don't tend to worry about too much from a clinical standpoint. And then there's patient factors, how soon they took it after the dose. Is your stomach full or not? Do you have gastroparesis, or do you have issues with stomach emptying? So are you taking other drugs that prevent your stomach from emptying on a regular basis, anticholinergics, opioids, etc.? The gastric pH, and then I put this last one of posture. And so I found this study, I thought it to be really interesting. This is called the Stomach Sim study. It was done at a group in Johns Hopkins. And they basically simulated the transit time of the pill, depending on which way you were laying. So if you're upright versus you're lying on your right, versus you're lying on your left, versus you're lying on your back. And what they found is there was actually very wide variation, that if you stood up, if you're standing up, that pill goes down in about 23 minutes. And it's in your small intestine. If you're leaning right, actually, that was the best way. If you're lying on your right-hand side, it's down in 10 minutes. And it has it's a function of the gravity and just the, sort of the shot into the small intestine. The slowest actually turns out to be if you were leaning on your left-hand side. So leaning on your left-hand side, it took about 100 minutes. And you can see down at the bottom that the drug isn't all the way through yet. And then if you're leaning back, that was also about 23 minutes as well. So the fastest is if you are upright, and then if you're leaning onto the right, or if you're lying on your back, that was the next. So it turns out then, is there an evidence-based rule of thumb? So when you survey providers again, there's no great evidence, and they've factored in a lot of different things. But it turns out that this 30-minute rule over 23 minutes, if you're standing up or lying down, turns out to be pretty close. So 60% would redose within 30 minutes of vomiting, 32 would redose within 15 minutes. So, you're sort of in that 15 minutes to 30-minute window. 8% sort of made it up as they go, but no one would redose after 1 hour of vomiting. So that's your window is about 15 to 30 minutes. And interestingly about that, it's close to the simulation studies, and they're done like 10 years apart. So we're going to talk a little bit about hypersensitivity now. So this is case 3. So you are evaluating a 43-year-old MSM for treatment of Neisseria. He notes that he had an itchy rash to oral penicillin in the past, but no difficulty breathing. Do you A, administer full dose ceftriaxone alone, B, pre-medicate and then give full dose, C, give a test dose, observe 1 hour, administer full dose, D, give azithromycin gent, or E, give cefixime? Okay, let's see what people said. There we go. Okay, so most would give full dose, followed next by pre-medicate and give a full dose. The next most common, I think it's a sort of a tie, is give a test dose or give azithromycin gent. And then we have 8% who would give cefixime. Good, all right. So the answer is actually A, give full dose ceftriaxone alone. And so these are numbers that I'm sure you know about why it's important that we get the numbers, give antibiotics correctly, why we try to get the allergy information right. The two things I would key in here is that 80% of patients with penicillin allergies lose their sensitivity after 10 years, even if it's an IgE-mediated hypersensitivity. And when you have to use an alternative agent, that outpatient prescription cost is not insignificant. It can be almost up to $200 per patient per drug. So this is why it matters to get it right. And it turns out that most people who say they have an allergy actually don't really. So that's another reason for us to really think this through. And again, this is stuff you already know. Why do we get the allergy information wrong? I think one of the things that we have to really be careful about is, we're risk adverse, so we don't want to test it out. We don't want to be the one that try that. But when we do realize that the antibiotic allergy information is incorrect in, say, the medical record or whatever, we really have to try and fix that. So there's a big push now to delabel antibiotic allergies when people get them wrong. Because if you don't delabel it, this issue comes back the next time the patient comes into care, right? Then you have to go through all of this again. And it's also very possible that the patient on the next go around will get something wrong, okay? So I know we're all risk adverse and we're unwilling to override those allergies or to sort of test the waters on that. But when we do figure it out, we have to do our best to educate the patients and to document it as many places in their medical record, as well as sort of try, if we can, to delabel that antibiotic allergy in the medical record. This is the timeline of drug hypersensitivity reactions, which I know you already know. And we're really focused sort of on this early few hours in terms of IgE-mediated reactions versus rash. So this is the part we're going to focus on when we talk about how do we figure it out. My slides don't always want to move forward. So in the past, we used to, do this blanket. There is a 5% cross-reactivity between pens and cephalosporins. Over the past 10 years or so, we've sort of learned that that isn't really necessarily the case. And there are definitely differences between the penicillins and the different cephalosporin generations. And that's due to this side chain on each of the beta-lactams. So you can see between penicillin and cephalosporins, you have the same beta-lactam ring, and it's this R1 side chain that really determines what the activity is of that drug against different bacteria, but also defines basically how reactive it is. It turns out that the highest cross-reactivity occurs when you are using an aminopenicillin, such as amoxicillin, and a first or second generation. Beyond that, there's very little cross-reactivity with the third generation cephalosporins. And so this is sort of what we saw as the past, right? So penicillins have a global overall 2% reactivity rate with cephalosporins. And now we have to really think about that 2% really depends on which generation we're talking about. And these are just for completeness, the other drugs that we don't tend to use on the outpatient, but clearly are very important on the inpatient side. This is a totally crazy chart, but this is how we figure it out. And you can look up this in this reference on the bottom. If you look online, many institutions have the side chain cross-reactivity matrices. And basically what it tells you is if you are on the left-hand side, if you have a reaction towards pen, can I go across and see if I'll have a reaction to something else? So something else that has a orange box definitely is a no-go. Okay, so you can see then from pen to across to cephalosporins, especially to the 3rd generation cephalosporins, the cross-reactivity is non-existent. Okay, so that means that you can safely give a 3rd generation cephalosporin to a person with a penicillin allergy because that R1 side chain is so different. And the last thing that I just wanted to mention is cefazolin, which is actually given a lot in the hospital for skin soft tissue infections and for surgical prophylaxis. That's this column here. You can see it has like no side chain reactivity to almost to anything. So just because you have a reaction, you can still safely give cefazolin in those patients. And this is a paper that was published last year and is actually based on our UCSF institutional guideline. So how you assess risk, so minor reactions meaning intolerances, and then you have other reactions. The ones that you would be most concerned about are these, the 3 on the right. So severe reactions that cause mucous membrane effects like Stevens-Johnson's, toxic epidermal necrolysis, stress. These are ones you would obviously not challenge, right? And then so when you get to these skin reactions of whether or not they have hives or IgE-related reactions, these are the ones you have to think about a little bit more. And so we have pathways for these now. So you can see then when it's just itching, the ceftriaxone is more than okay. If you're high risk, many would do a test dose. And in the hospital, we always do this just as a standard of practice, and then we move forward. If the side chain that they are reacting to is similar, that's when you have to think about it a little bit harder. And that's when you go back to that first matrix. And then for cephalosporin allergy, if the patient says, I'm allergic to cefazolin, I can't get ceftriaxone. If it's a low risk reaction, go for it. If it's a high risk reaction or if it's recent, that's when you start splitting yourself out between a 1st, 2nd generation reaction versus a 3rd, 4th, 5th, right? So a 1st and 2nd generation reaction likely will not have any cross reactivity over, and those are okay to give. But again, some people would feel comfortable giving a test dose. We always do that in the hospital. That would be okay to do as well. So of course, good history taking is always very important, education. My favorite one out of these is, what other antibiotics have you taken? And the only reason I like that one is because a lot of patients will say, oh, I cannot take any penicillin. No, I can't. And then you ask them all the drugs that they've taken, and they've taken amoxicillin, just because they don't even know it's within the same class, right? So that's always important. The other way that's important is to figure out which antibiotics they can safely take. So if they said, I'm truly allergic to this, and you document it, they can tell you, oh, but I can really take this one, and that's okay. And lastly, in the next 5 minutes, we're going to go over drug-drug interactions. So this is the last case. A 56-year-old male presents with COVID. His current medications include amlodipine and simvastatin. You prescribe nirmatrelvir ritonavir, which is Paxlovid, and you counsel the patient to continue the simvastatin, continue the simvastatin at half the normal dose, stop, but restart when you as soon as the nirmatrelvir ritonavir is completed, or you stop and you restart 5 days after completion. So I know this is a COVID case, but because the concepts of drug interactions are the same, I thought it would be interesting to go over. And this has become like one of the most common questions we get. Okay, let's see what you guys said. Where'd it go? All right. So it's very clear, a lot of you guys know how to manage drug interactions. So the correct answer is D, stop simvastatin, restart 3 days after completion of nirmatrelvir ritonavir. 23% of you were split on whether or not to continue it or to stop it, and that's okay. And then 3% said to continue at half the normal dose. So I will tell you, we have had cases of patients who have continued their statins and ended up getting rhabdo. So I probably wouldn't do that one, just because not all of those kinetics are linear. So halving the dose doesn't always give you half the effect. Okay, so we looked at this before, how drug metabolism takes place. And again, the only reason I have this here is just to show you that the liver is basically the machine in the body, right? It takes care of everything. And CYP3A4 interactions are just one of many, many drug metabolism pathways that occur in the liver. And all of these, the whole point of metabolism is to basically detoxify the drug and to make it soluble enough for your kidneys to excrete it. So this is basically drug metabolism in a nutshell. So I have this Pac-Man thing as the CYP enzyme and this green triangle as being the substrate. And so when you have a CYP enzyme and it binds the drug, you have detoxification and the concentrations of this substrate go down, right? So that's normal metabolism. When you have P450 inhibition, what happens then is you have another drug around that's an inhibitor that binds up the CYP enzyme and that makes it so that your regular substrate cannot bind. It's a little misleading here because the way I drew it makes it look like it's a competitive inhibitor. That's not always the case. You can have the inhibitor bind somewhere else on the enzyme as well, but the net effect is that your substrate cannot bind. And what happens is you get increase in drug levels. So the onset of this inhibition is actually fairly immediate. It's pretty much as soon as you start the second drug, the inhibiting drug. And how long it lasts, though, it sort of depends. It depends on whether or not that inhibitor is a competitive versus a non-competitive inhibitor, and whether or not it's a reversible binding versus a non-reversible binding. From an end perspective for the user, that's hard to sort of wrap your head around. So the basic rule of thumb then becomes 3 days after the discontinuation of the inhibitor. And so examples of the inhibitors I have below, ritonavir, azoles, and clarithromycin being big ones. So when you have induction, this is a little different. So the inducer then makes your body create more CYP enzyme. So if there's more CYP enzyme around, there's more enzymes to bind up substrate. And then what happens is your drug levels go down. The onset of this is a little bit different. So that can take up to a week to take place. And we've seen this in patients who say who are on methadone and then end up going on, say, rifabutin. That induction effect usually kicks in after a week and they start losing the effect of the methadone. But the duration also lasts much longer after discontinuation of the drug. So you have to give it time to sort of wash out. So these are some good references. And I put here that these are two great interaction checkers for HIV drug interactions and for COVID. This is from Liverpool. It's the Liverpool drug interaction checkers. And I love it because they actually, when you put your information in, they actually give you the rationale behind their recommendation and the quality of the evidence. And when possible, they will actually tell you what to do instead. Okay. And with 1 minute left to go, I just have here a list of sort of all the different places you can go to get good information for free. So whenever you're asked these pregnancy questions or lactation questions, LacMed is actually the best place to get that type of information. If you're looking for herbs and supplements, Medline is really good as well. So with that, I apologize. I wanted to finish sooner, but I made it just on time. Thank you very much. And I, of course, will take any questions.
Thank you so much, Kathy. Dr. Yang, that was fabulous. So informative. And you have a lot of questions, which I'm sorting through, and I apologize in advance if we can't get to all of them. Let's see. One person had just a very simple question to remind you what the AUC, what those initials stand for again.
So the AUC stands for the area under the curve, and it's just a measure of how much drug exposure you have. So it's you can think of it similar to like the peak concentration. It's just how much drug you have in your body.
Great, thank you for that. Question about someone sharing a concern about using bicillin in someone who has a history of mild penicillin allergy, feeling more comfortable using ceftriaxone. So thoughts on giving bicillin long-acting when someone gives a report of having a mild penicillin allergy in the past. Any input or thought on that?
A mild penicillin allergy?
Yeah.
So like something like a rash or like an intolerance of some sort, those I would be comfortable with as long as it's not something that is, a desquamating rash or it's a hypersensitivity reaction. I'm okay with that with good counseling.
Yeah, so what you're really raising is the issue of getting a really good history in that patient on their allergy in the past. So thank you for that. Let me just scroll down. All right, you're getting a lot of thank yous. There was one other question. All right, question related to Flagyl. So in the case of throwing up, having emesis with Flagyl and redosing, person asks, wouldn't the patient now have one less pill and be receiving an underdose?
Yeah, so whether or not you have to give that person another prescription sort of depends on how long you've treated the patient, right? So, or how long you intend that duration of therapy to be. If it's something that's a short course therapy, percentage-wide, of course, that makes a bigger difference than you would have to give them an extra dose. If it's something that's a long course of therapy, we fudge this, right? So if you're talking about something that's 10 days of therapy and they missed one dose, proportion-wise, that's turns out to be not as big a deal, right? So it sort of depends on the duration of therapy of what it is you're treating.
Great, thank you for that. Someone is asking, could you show the reference slide again for the drug-drug interactions? It's one of your slide set.
This one? This one.
Let's see. I think that is the one. Just seeing if there's any
with
other.
the web link. Oh, with the web link. So the web link is down. There's multiple places you can find the web link. So this is all from Liverpool. So this is the COVID one, but there's also an exact replica of this for the HIV ones as well. So, and it comes out the same way. So you just put in your drug, your COVID drug, your antiretroviral, and then your co-medication, and then it will tell you what to do with that drug interaction. And one thing I forgot to mention is I put a little star up here because they have always this disclaimer. If a drug is not listed, it cannot automatically be assumed it is safe to co-administer. Because what that basically means is all of these are based on some type of evidence of what that interaction was, right? And if they don't have any information on that interaction, you can't make an assessment if you don't know if it was metabolized by that enzyme or there's no data. For the most part, now all of these drugs have to have these type of metabolism studies done before the drug goes to FDA approval.
Great, thank you. I think that folks also would love to see the slide before, and I'll just let everyone know who's putting questions in. You're going to get this presentation and you'll have access to the recorded slide set. So you'll have all of those materials, but maybe this is the site that folks were looking for. Okay. Question about, this is an interesting one, the possible reaction of alcohol while taking metronidazole, which we know that there's been some changes in the guidelines on that one.
I thought about actually putting this in, and I have to tell you a funny story if everyone would just give me a minute. I was actually at lunch once with one of my best friends, and her husband dropped us off, and he was taking Flagyl for something, and he was like, I'm going to drop you guys off and I'll come back and pick you up later. And at lunch, he drinks a beer. And he wigs out, he freaks out, he calls me on the phone, oh my God, I drank a beer, am I gonna throw up? And he had taken actually a pretty large dose of Flagyl. And so when you actually look at the data, it's not that compelling that that alcohol and Flagyl has this interaction. So for the most part, it's okay. It sort of depends on how much alcohol you drink. And for a beer, that amount of alcohol is very low. And of course the timing, but the case reports of people who get this disulfiram reaction are not that common in the literature. But for him, because it was all over his prescription bottle, he was so focused on it, he wigged out, and then he was like, I'm gonna go home. He actually, when he came to pick us back up, he had lined the car with some plastic because he was so anxious about throwing up, as opposed to actually getting sick from the med. Like I think he did have a little bit of flushing, but I'm sure that was just anxiety. And so the problem with this is, if you look at the data, it's not that compelling, but that label is always on the bottle. So it does take a little bit of education to say this, you probably shouldn't, but if you don't freak out about it. You're not going to get sick. You're not likely to get sick, but that warning about the alcohol always remains on the bottle.
And interestingly, the CDC guidelines has shifted to say that you don't need to worry about that alcohol and metronidazole. So they looked at a study, I think it was from Norway. It was from another country that had reviewed a lot of the data around this. So I think that we're 1:06 now, and we have a couple more questions we haven't answered, but I think we're going to have to conclude. Actually, can you stop sharing for 1 second? Because I want to share my screen just to share the CME information with folks. So just to remind folks about getting CME. If you stay with us this long, you have watched the webinar in full. Just keep an eye out for the post-course survey evaluation. And again, thank you everyone for being here. Thank you, Dr. Yang. This was a fabulous presentation. I learned a ton. You're getting a lot of kudos in the Q&A. You got them before. And so we really appreciate your time. Have a wonderful day, everybody. And we look forward to seeing you at our next STI expert webinar. Thank you.
Thanks, everyone.